Hello, everyone. Thank you for coming. Welcome to NADO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee's screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Well, thank you, Erica, and thank you everyone for joining us again for this breakout session. It is my pleasure to introduce this session, which is Value and Analytics, Healthcare Outcomes. This session was organized by Kenley Money, NADO's board chair, and I'm going to go ahead and bring Kenley to the stage and turn the time over to her, who will be our moderator for today. Kenley, the stage is yours.
Thank you, Norm, and hello, everybody. Hopefully you were able to have some lunch and enjoy the keynote this morning. It was very, very interesting. I'm happy to bring to you today's session, Value and Analytics Healthcare Outcomes. I've heard over a couple of times over the past 2 days phrases like turning data into information. Data is fine, but knowledge comes from information. The translation of data into information produces value. Various paraphrases of that sentiment. The idea, though, is data turned into information produces value. And so that's what we're going to talk about today. I'm excited to share with you 3 presentations that do just that. Let me get my crib notes here. The first one is, and I'm going to introduce each, and then at the end of my introduction, we'll go into all the videos. The first one is Data Sharing and Integration as Tools to Improve Health Outcome by Deja Kemp, Director of Legal Policy from the Actionable Intelligence for Social Policy, or AISP. The second is it's from the Massachusetts SMM project, a novel quality improvement intervention to improve SMM identification and administrative data. Whew, big, big title, by Nairi, Kalpakian, my apologies, and Godwin, Osei-Polu from the Betsy Lehman Center for Patient Safety. This is a real-world example using information to address an alarming and growing issue with maternal health. And then the last is Colorectal Cancer Screening Uptake with Alyssa Harris and Hannah Murphy from Vizient. Some housekeeping before we begin. There'll be an opportunity to, after each speaker, each presentation, to ask questions. So please put your questions in the chat and we will get to them. And then at the end of all 3, after each, the presenter will come on stage, and at the end, after all three presenters will come on stage so that you can ask them all questions in context. So without any further ado, I'm going to ask Norm to begin the first presentation, which sets the foundation of how to approach analytic questions to turn data into information.
Thank you for joining. My name is Deja Kemp. I'm the Director of Legal Policy with AISP. And today I will be talking about data sharing and integrations as tools to improve health outcomes. So a little bit about AISP. We are housed at the University of Pennsylvania, and we are tasked with helping state and local governments share data to improve lives. It's helpful to let folks know about our role, and we like to start by telling people what we are not. So to begin with, we are not data holders or intermediaries. We don't hold data on behalf of anyone. We are also not a vendor or recommender. We're not trying to sell you anything. And we are also not focused solely on academic research. Instead, we like to describe ourselves as data evangelists. We like to spread the good news about data sharing. We connect folks and affectionately refer to ourselves as data sharing therapists. And we are also focused on ethical data use for policy change. This is a picture of our team. We are small but mighty, and you can also learn more about us at the website link below. As noted before, we serve a network of over 40 jurisdictions. This is a map of who we support. We are also connected with the International Population Data Linkage. So to begin with, I like to make sure that we're using the same terms. So you might hear me talk about data sharing and integration, and what do we see as a difference? So with these two figures, you can see that data sharing are often where agencies, will share assets, but data integration is a more complex type of data sharing where we are actually linking individuals and different data sets via their identifiers. So what do I mean by human service data? I'm talking about data that is collected during the routine process of administering programs that folks can also repurpose and reuse for different purposes like evaluation, analysis, and research. And when we are talking about human service data, we're also talking about different domains. So that could be in education, that could be in behavioral health. That's what we mean when we say human service data. And we know that linking these data can give us some pretty powerful outcomes. When we link this data, it helps us to understand the complex needs of family, helps us to allocate resources where they're most needed. We can measure the impacts of programs, and we can engage in transparent decision-making about how those data should be used. Because we are working with data with identifiers, there are some just clear tensions in this work. There are some risks of specifically privacy risks related to these data, the risk of reuse and disclosure, but there are some significant benefits that these data can tell us to improve communities. So in this work, we are constantly balancing these two tensions. Folks, what we have learned from doing this work for a long time is that people, when they say they want clean linked data, what they actually need is governance, right? They need a process for figuring out what projects should be conducted. They need deduplication and reconciliation of records. They need standard definitions. They need legal frameworks. And all of these things summarize what an integrated data system does. We have come up with a quality framework for integrated data systems. So we think that these are the 5 essential elements that make these integrated data systems work. One of those elements is governance, which we describe as the people, policies, and procedures that support how these data are used. Then there's the legal, so the legal frameworks that facilitate the sharing, the technical, so the infrastructure and systems to support that, capacity, so the staffing and relationships needed to make happen, and the impact. And this is where we measure what these integrated data systems do. When building out these systems, we have people think through these basic 4 questions that I'll talk a bit more about coming up. So the first question we have people think about, and we consider this to be the lowest bar, is this legal? And most of this is going to be informed by authority and access. So what do you plan to do with the data? Who do you plan to share it with? And these are the legal authority that folks use to establish the basis to be able to facilitate these exchanges. The second question we have people think about is this ethical? And when we're thinking about that, we think about risk versus benefit. Who will benefit and who are we asking to bear the risk? And another thing to think about is social license, which is the perceived legitimacy of a project from the public. And this matrix here highlights what we consider to be problematic and positive practices. The third question we have people think about is this a good idea? So just because it's ethical and it's legal, it might not always be a good idea. And the way to get to that, we ask questions like, are there available data to answer the question? Do we have the resources? Can these data be acted upon? Sometimes what we have seen is that some projects are just a summation of things that we already know, and that might not be the best use of public monies. The last thing, and one of what we view as the most important question, is how do we know and who decides? And the answer to that is data governance, which again are the people, policies, and procedures to help us answer the questions that we said of, is it legal, is it ethical, And is it a good idea? And in our view, strong data governance should be purpose and value driven, strategically located, collaborative, iterative, and transparent. So what does data use actually look like, and specifically as it relates to health outcomes? So I wanted to flag a existing university public partnership, and this specific one that I'm lifting up highlights just a foundational report on workforce. So with this particular this particular partnership, which is housed at the University of Denver, when the COVID crisis hit in 2020. Agencies were scrambling to help families, especially essential workers, find childcare. And so what this IDS was able to do was to look at data behind an already in progress report to create workforce lists for agencies. And as a result, agency outreach to 30,000 providers and creation of a job board for temp positions. And they were able to do this with their existing data that they already had. Some state examples of how folks are using integrated data. Colorado is doing it to help families find childcare. Again, Indiana doing it for COVID vaccine research and response, and California using integrated data systems to support new parents. But local counties and cities are also doing this work too. So an example is the Charlotte Regional Data Trust, where they've used integrated data to do some analysis of youth homelessness. The Metro Atlanta Policy Lab have done things to figure out how to best distribute pandemic EBT. And then you also have the Baltimore Youth Data Hub that is looking for ways and evaluating programs to figure out how to reallocate funds. There are places all over the nation that are doing this exciting work, and integrated data systems can be a powerful tool for health outcomes. Thank you.
Thank you so much, Dave.
Thanks for having me.
Yes. Well, first let me say that I am a big believer in building a foundation, and that's what you describe. I'm a believer in thinking through and around an analytic question and the data required to answer it. And this approach provides a great framework. So yay, I'm your cheerleader. It's awesome. Has AISP been engaged with a state to build an all-payer claims database or an analytic environment?
Yeah, so we, as noted, so we support a network of over 40 jurisdictions, and some of those are actual health departments. We provided some pretty extensive support with the state of North Carolina, the Department of Health and Human Services, and our activities range from that. A big part of what we do is help folks, answer these big questions and give them the tools to kind of figure out a lot of the basics. So we're not out here helping folks figure out like their technical infrastructure. That's a little bit above our pay grade, but what we are doing is helping folks figure out what are the legal frameworks you need, who do you need to hire to be able to, facilitate those type of exchanges that you just discussed. So a sizable portion of our network are, folks involved with health data.
What is the biggest challenge for folks who begin this journey? What have you run into the most that potential partners struggle with? Yeah,
so there are four main challenges that we see. So the first is around building relationships and building trust. People, rightfully so, are anxious about exchanging this type of data with identifiers. So again, building those relationships. The second one are legal issues. So either that can be real or perceived legal challenges. There is no uniform federal privacy framework like the EU. And so states and localities are left to fill in the gap. So there's like a patchwork of regulations and there's not so much guidance out there. So there's that. The next issue are in terms of capacity and just resources. Again, a lot of these state and local governments are, pressed for resources. So trying to figure out how to staff these. And finally, there are technical issues. So some of those might be inflexible legacy systems. And so a workaround that we tell with folks is like, start small, You don't have to initially start with data integration, which involves more complex linkages. Start with data sharing if you need to. And also, yeah, start small and then like really lean in on those relationships.
There's a comment in the chat, and it went away. It was thank you. There it is. And I completely agree. These 4 questions to ask is helpful to organize the New Mexico PCD data requests. She wants your deck. Paige does.
Perfect. Yes. And I think the organizers will make sure that y'all have access.
Yeah. So the next question is, how do you ensure data consistency and accuracy when combining data from multiple sources?
That is an excellent question. That is above my pay grade. I am the one lawyer on the team. So I do know that in these places, we have excellent like data analysts in these jurisdictions that are ensuring like accuracy. Our job is to make sure that folks have the infrastructure, so the legal frameworks that they need to be able to legally be able to link the people and places in there. But in terms of like how do they ensure, that is a little bit above my pay grade, but there are excellent, talented folks in our jurisdiction that can answer that question. And you can also reach out to me separately, and I'm happy to connect you with someone.
So I can see the framework you described being like a governance model to identify and apply whatever is required for data consistency. And it's very good. So I'm going to leave you with one other question. What's the one piece of practical advice you would give someone starting this?
Yes. Start with the use case. I have found, especially as a lawyer, that some folks come and say, give us everything and we'll figure out what we want it for. When you really, really need to figure out the reason why we can't give you the kitchen sink. You need to figure out the purpose for why you want it and go from there. So I would say start with the use case as opposed to asking for everything. I think that's going to take you a far way. And then the other tip, even though you didn't ask for that, the second thing is bring lawyers early and often. The worst case scenario is that folks have decided, oh, we're going to share all this data. Here are the agreements. You give it to your lawyer and say, can I sign it? And then 2 years of work went down the drain because they have to tell you no. So start with the use case, bring in lawyers early and often.
Words to live by. I love that. Well, thank you so much, Deja. We're going to move to our second presenter. Deja's description built a foundation, in my opinion, of best practice to approach value-based analytics, and the next 2 presentations clearly have followed that. And so let's actually look at examples of real work done based on these very excellent governing principles. So our next presenter is Nairi and Godwin from the Betsy Lehman Center for Patient Safety. And when they come on, I'm going to Nora.
Hello, my name is Megan Carney, and I'm a maternal health research manager at the Betsy Lehman Center.
Hello, my name is Nairi Kalpakian, and I am the maternal health research assistant also at the Betsy Lehman Center.
The Betsy Lehman Center is a state agency in Massachusetts that manages and facilitates research, data analysis, and programming to improve patient safety in healthcare settings. We are an independent entity within the Center for Health Information and Analysis, another state agency who acts as a steward of statewide health information. Our current research work at the Betsy Lehman Center has primarily focused on maternal health patient safety, and today we're excited to share a bit more about our recent project in developing and assessing a new QI intervention and identifying SMM events using hospital administrative data. Severe maternal morbidity, or SMM, is one of the most frequently used metrics for studying maternal health in the U.S. According to the CDC, SMM is defined as unexpected severe outcomes during labor and delivery that can result in significant health consequences. Under this definition, SMM events are captured by the presence of 21 indicators, listed to the right, which are identified using ICD-10 codes found in hospital discharge data. There are various definitions of SMM, but our team at the Betsy Lehman Center uses the CDC's in our maternal health patient safety work, which includes monitoring SMM rates across the 40 Massachusetts birthing hospitals. Using the CDC's definition of SMM has been useful, however, it's not without its downsides. In Massachusetts, hospital discharge data typically exhibits a lag from when it's collected by hospitals to when it is available to CHIA and the BLC for analysis. The delay in data means that hospital teams do not receive reports of their SMM cases and rates until about 1 year later, thus preventing them from addressing SMM events in real time. Additionally, a disadvantage of the CDC's definition is that it was developed as a population health surveillance metric, not as a clinical metric. This raises questions of the measure's validity and acceptance among clinicians. Therefore, we propose a new intervention to support hospitals in tracking SMM. So with this new intervention, our team had two main objectives. One is to provide timely SMM data to hospitals to improve quality improvement efforts, and two is to engage providers in assessing whether cases identified using the CDC's SMM definition were clinically relevant events. So next I'm going to go into our intervention and our analysis. So our pilot intervention is built upon the existing process Massachusetts hospital data submitters are asked to follow when submitting data to CHIA. For context, hospitals are required by state statute to submit hospital discharge data to CHIA every state fiscal year quarter. However, as part of our intervention, we are asking hospitals to submit data monthly instead of quarterly. Once a hospital submits data to CHIA, CHIA will intake all delivery discharge records and then send a clean data set to the Betsy Lehman Center. Betsy Lehman Center then runs analysis and tasks to identify SMM cases for each hospital. Identified cases are then securely shared with backup provider teams in which they are asked to confirm the identified SMM events with their medical records. They then send confirmation back to us, and then we save those final confirmed cases and rates in a secure Tableau dashboard in which hospitals are able to access in their browser to see their institution's SMM rates in a more timely manner. Overall, we wanted to make the intervention as simple as pushing a button for hospitals. I also wanted to mention that we selected to use hospital discharge data as opposed to APCD data for this pilot because first, we felt that it was feasible to obtain discharge data directly through CHIA in a timely manner. And we also felt that discharge data includes information on race ethnicity, which we wanted to stratify SMM rates by. So we started our SMM monthly data extraction pilot in June 2023 with 3 hospitals. We then expanded to 9 academic and community hospitals participating in June 2024. Using hospital discharge data, we are able to review and confirm SMM cases as far back as October 2022. And using the process detailed in the previous slide, the data lag from submission to final review was cut down to around 6 to 8 weeks. And this is an example of our Tableau dashboard. This chart, for instance, shows the trends in SMM rates among individual hospitals with outlier month flags. I'll now shift it over to my colleague Nairi to go into our analysis and findings.
Thank you, Megan. In addition to providing timely data to hospitals, a second objective of our pilot was to examine the effectiveness of using the CDC's definition in capturing clinically significant SMM events. We did this both quantitatively and qualitatively. For our quant analysis, we documented the number of deliveries and number of SMM cases each month for each hospital in the pilot between October 2022 through June 2024. We reported SMM cases back to hospitals at the indicator level, given that a patient could have more than one SMM indicator, for example, DIC and hysterectomy. In their review, clinicians flag whether an indicator identifies a clinically relevant or confirmed SMM case or a not clinically relevant, or in the terms that we use for this project, false positive SMM case. Patient-level false positive SMM cases were also tracked to record each hospital's overall SMM rates. Regarding the qualitative data analysis, we reviewed free text narratives from case reviews from clinicians and categorized false positives or the reported cases that were confirmed not to be clinically relevant SMM into 3 groups. The first group is coding errors in problem identification. So we used this code when it was suggested a wrong ICD-10 code had been used compared to the clinical notes. The second grouping is pre-existing conditions or conditions present upon admission. And the third grouping that we used was inconsistent applications of SMM definition. This was used when there was evidence of a SMM indicator in the clinical notes, but after further review, it was deemed not a clinically relevant case. So the 3 study team members independently coded the narratives in Excel, assigning 1 error type to each case, and all 3 met and reached a consensus on the narratives that they all assigned to the cases. Now for our findings, overall, After reviewing cases, the clinical teams from our pilot hospitals agreed with 69% of the SMM cases our team identified through analyzing HDD data. The agreement rate ranged from 57% to 76.7% among academic medical centers and 50% to 100% among community hospitals. There was one hospital that recorded no case of SMM during the pilot and is thus not shown in the figure above. There was a lot of variation between indicators in the reasons behind the disagreement. From our analysis, we determined that an inconsistent application of SMM definitions was the most common reason for flagging a case as false positive, accounting for more than half of the disagreement rate, approximately 59%. This was especially common for acute renal failure, sepsis, shock, acute myocardial infarction, and sickle cell. Coding errors accounted for most of the disagreement for air and thrombotic embolism and all of the cases for amniotic fluid embolism, hysterectomy, and acute respiratory distress syndrome. 82% of puerperal cerebrovascular disorder false positive cases and the majority of the pulmonary edema / acute heart failure cases were pre-existing. And with that, I'll hand it back to Megan.
Thanks, Nairi. So with that, I'll go into our implications and ongoing work. So we found through this project that there is value of using the CDC definition as screening criteria for identifying SMM cases in hospital administrative data. As highlighted by providers in this pilot agreeing with cases being clinically significant almost 3/4 of the time. However, incorporating timely clinical review is encouraged for effective quality improvement. Through this project, we found that hospital teams continue to use different definitions of what constitutes an SMM event outside of just using ICD-10 codes, without consistent specific guidance of how some of those diagnoses indicate an SMM event. To address this, we recommend collaboration among clinicians, hospital coding teams, and other relevant stakeholders to identify clear clinical practice guidelines, protocols, and coding instructions for flagging SMM events consistently within and across facilities. Specifically, collaboration between clinical providers and coding teams is essential to minimize the number of incorrectly identified SMM cases. So after receiving feedback indicating hospital differences in SMM, we can be in learning collaborative with all the participating program hospitals to discuss and identify best practices in coding, as well as to reach a clinical consensus on how to identify select indicators as SMM events. Through this learning collaborative, we have also been working with the CDC to strengthen their SMM coding algorithm. They are already doing work in this area, and our hope is to provide more insight on what is occurring on the ground in hospitals in identifying clinically significant SMM events. Finally, we are still running the program with up to 12 hospitals now, with more expected to join in early 2025. And with that, thank you so much, and we'll open the floor to questions.
Thank you, team. I should have said earlier that Megan couldn't make it, so Godwin is her proxy. And I'm sure, and he's got it covered. So thank you so much. As when I listened to this presentation the first time and again now, I'm curious. It was clear that, and we've all experienced it, inconsistent coding creates noise and trouble, regardless of the analytics subject. And you stated that you changed the frequency that you receive hospital discharge data from quarterly to monthly.
Yes.
In Arkansas, we get it annually because there is a very long validation period to ensure that it's accurate. And I expect the same thing happens. But did the noise from mistaken coding increase when the submissions became monthly? Did it miss a validation step?
No, we don't think so. The Center for Health Information Analysis, our sister agency, they graciously agreed to sort of fast track this process for us, and they have a very robust system for making sure that the data that they get and release to us is accurate as possible. Okay. So we didn't really notice a change in sort of the noise around coding errors over time.
Okay, great. Norm, is there a question from the audience? There we go. Izzy Montgomery, she's from ACHI. Apologies if this has already been addressed, but how many of the state's birthing hospitals participate in this initiative?
I can address that, and Godwin, feel free to also add. As of right now, I believe we have 12 hospitals for this specific project. I think we limited it to 8 because of the availability of the data for the time period that we were looking at. And I might, yeah, so Godwin, yeah, again, feel free to correct me if I was wrong and misremembered, but yeah. So there are also like currently in Massachusetts 40 birthing hospitals. So we are only doing like just a small bit of the total amount of deliveries in the hospital, or in the state. But yeah.
Yeah, it's a sort of the project is supported by HESA grant for 5 years. So we're hoping to ramp it up and get all 40 hospitals doing this at least in one way or the other. Our goal is to get to maybe 20 by the end of this fiscal year, but that is sort of an ambitious goal, but we'll settle 15 if all hospitals, a few more hospitals are interested in the project.
An audience, as he says, great, thank you. So, another question, great. Helen Fig, curious, should you always keep the raw data as a standalone deliverable once any analytics are performed on the data?
Yeah, we have the raw data itself that is sort of saved, and then we run analytics and then sort of generate the data for others. So we do have the raw data to always go back to if there are any issues. Yeah, I don't know if that's sort of the question. That's the question that Helen is getting at.
So I have a question. When you add a hospital, are you able to do the analytics on the one and include in the big picture, or do you have to run everything again? And how long does it take?
So I guess our monthly process, like it always incorporates like all of the hospitals, like what we're looking at. And I mean, and then we also like sometimes we also definitely look at like how perhaps the data might have changed like with each submission. Maybe this was like flagged as a delivery like last month, but it actually isn't a delivery anymore. So we kind of just like, it's a very iterative process. Like we're constantly like checking ourselves to make sure that what we're reporting hasn't like drastically changed from last month to this month. But I guess to address the question, like, yes, we like kind of run the numbers on all the hospitals monthly. Yeah.
Okay.
Yeah, the data is delivered to us as sort of an aggregate data cumulative every month. Okay. So when new hospitals join in, their data just added to the pool, and then that is given. We're able to go back and see the average from when the project started.
So just how are you collaborating with the CDC? One of your last slides said that. What is the interaction like? Is it regular?
We just sort of started that piece of it. We had when we were going through the project, we had a meeting with CDC. We actually even had them come to one of the learning meeting series to talk through SMM and how they're identifying it. And then, of course, they did ask us. So we developed this metric for population surveillance and research. So we're using it as a service line measure, right, as a clinical measure. And so we realized that for the past 4 or 5 years, we've been using that to sort of help hospitals track their QI initiatives. And so hospitals are leaning towards using this as sort of an outcome measure for most of their QI initiatives. And we think that there's some opportunity here for CDC to look at what we are doing and then hopefully be able to clarify some of the definitions. It's not all the indicators. There are some specific indicators where some clarifications are needed. And so we want to submit this data to CDC and then let them look at the specific indicators that we highlighted and then see if there could be some sort of discussions around how to streamline these definitions. One of our learnings in Massachusetts of the Learning Collaborative, we started working on acute renal failure and coming to some sort of standardized definition that all hospitals in the program can use. And we hope we want to move towards other indicators like sepsis, shock, and others. And hopefully we've started the discussion with CDC, we'll submit some of our data to them so that they can see where we are and what changes might be needed for them.
Have you seen any positive impact externally, even small, or are we still building the foundation?
Well, I think we've seen like definitely a lot of teams like take more of a focused effort in like reviewing this, the numbers and the data. And of course, the intention of this project initially was for that teams to build their own like internal processes so that like should this project come to a close at some point, they have something set up so that they can continually do their own like QI reviews. And so that's been like definitely really rewarding to see. As for like rates, well, I guess things definitely are shifting around a little bit, but it's like too soon to like tell conclusively. Yeah.
Yeah, one benefit is hospitals are now able to pinpoint specific indicators that are driving their SMM rates. So as you do the reviews,
Okay.
you realize that, okay, we have a high number of sepsis cases, so we should focus our quality improvement efforts on sepsis. So that is one benefit of it, and sort of the discussions some of the things we're hearing from teams is, okay, we are now able to pinpoint where to focus our efforts on.
Great. Okay, thank you. We're going to move to our next presentation, and everyone will be able to come back at the end. So let's take us to colorectal cancer screening uptake. Good heavens, my apologies. It's after lunch with Alyssa Harris from Vizient.
Hi, my name is Alyssa Harris. I am a research director at Vizient, and today I will be presenting on colorectal cancer screening uptake in individuals aged 45 to 49 in the U.S., subsequent to guideline changes. For background, colorectal cancer incidence in the United States has been decreasing since the 1980s. However, when you stratify that by age, there are three different stories that play out. The overall trends are being driven largely by the 65 and older age group, which you can see on the graph on the right. It shows that there is decreasing incidence in this group. When you look at individuals 50 to 64 in the middle graph, you can see that there have been slight decreases in incidence, but it has remained largely stable for the past decade or so. When we look at individuals less than 50, the incidence has been increasing since the 1990s and has been increasing at a rate of approximately 2% per year. Professional guidelines had recommended to start screening in average risk adults at age 50, but due to increasing incidence in younger individuals, in May 2018, the American Cancer Society lowered the age to initiate colorectal cancer screening in average risk adults to 45 years. In May 2021, the U.S. Preventive Services Task Force followed suit and also lowered their recommendation to initiate screening starting at 45 years. However, with these recommendations, both the ACS and USPSTF cited a lack of evidence of the effectiveness in colorectal cancer screening in the 45 to 49-year-old age group. The overall aim of this research study was to look to see if the changes in the ACS and USPSTF colorectal cancer screening guidelines resulted in an increased uptake in colorectal cancer screening in 45 to 49-year-olds. To answer this question, I looked at data in the Vizient Clinical Database, which is a comprehensive facility discharge database with data from over 1,200 hospitals, including over 98% of U.S. academic medical centers. The database contains over 14 million inpatient and 240 outpatient encounters per year. Within the Vizient Clinical Database, I pulled encounters for colorectal cancer screening in average risk adults between the ages of 45 to 75 years for encounters that took place between January 2016 and June 2024 based on ICD-10 diagnosis codes or CPT codes for colorectal cancer screening. I grouped the patients into two age groups, 45 to 49-year-olds who had newly approved guidelines for screening and 50 to 75-year-olds who had established guidelines in place for colorectal cancer screening. To look at the impact of the ACS and USPSTF guidelines on colorectal cancer screening uptake and patterns, the data was grouped into three study periods. The pre-updates period, which took place between January 2016 and May 2018 prior to either the ACS and USPSTF recommendation changes, an interim period from June 2018 to May 2021 after the ACS changes but before the USPSTF recommendations, and then the post-change period from June 2021 through June 2024. Encounters were excluded if they met high-risk criteria for colorectal cancer screening based on patient codes for family or personal history of genitourinary cancer or other conditions known to lead to higher risk of colorectal cancer. Using that methodology, I pulled 6,989,305 encounters for colorectal cancer screening. Here you can see a graph representing the monthly screening volumes broken out by the two age groups. The green line, which represents the 50 to 75-year-olds, increased throughout the study period. And you can see that even though screenings went to almost zero in April 2020 when elective procedures were canceled, screening has recovered and continued to increase since then. From the pre-updates to the post-updates period, screening increased 48% in this age group. This might be attributed to increasing awareness of colorectal cancer screening and goals in Healthy People 2030 to increase colorectal cancer screening volumes. The bottom line represents the 45 to 49-year-olds. In the pre-updates period, they represented 2% of all screening from ages 45 to 75. After the ACS guideline updates in May 2018, there was a slight increase in volume, but they still represented only 3.5% of all screening from 45 to 75-year-olds. After the May 2021 U.S. Preventive Services Guidelines updates, a very marked increase in screening in this age group can be seen, with a 1,374% increase in screening from the pre-updates to the post-updates period. In the post-updates time period, screening in 45 to 49-year-olds represents 18.2% of screening of all 45 to 75-year-olds. It's important to note that with the Affordable Care Act, any guideline from the U.S. Preventive Services Task Force that receives a grade A or B must be covered as a preventive service by insurers. And the same does not apply for insurance reimbursement for recommendations from other societies like the American Cancer Society, which could explain the uptake after the USPSTF recommendations. I wanted to compare some of the demographics across time, so I looked at the 45 to 49-year-olds who were screened in the pre-update period and compared them to the post-update period. So individuals aged 45 to 49 in the post-update period were more likely to have a commercial payer, 6.8% higher. They were more likely to be Hispanic, 5.9% higher. They were less likely to be Black, 8.1% lower. And there were fewer high vulnerability patients based on the Vizient Vulnerability Index, which looks at life expectancy based on the patient's zip code. And there were 8.5% fewer of those. This indicates that overall, most of the patients who had screening in that post-update period were less minority and lower vulnerability than the pre-update period. Looking at that post-update period, I also wanted to compare the older 50 to 75-year-old age group to the 45 to 49-year-old age group just to see how their demographic variables differed. So the younger group compared to the older group were more likely to have a commercial payer, not surprising given the high representation of Medicare in the older cohort. They were also more likely to be Hispanic by 2.8%. They were less likely to be white by 4.4%, and they were more likely to be female, 2.8% higher. So overall, following the ACS and USPSTF in particular recommendations to lower the age of screening from 50 to 45, there was over a 13-fold, almost 14-fold increase in screenings among individuals 45 to 49 in the US. Over the study period, both 45 to 49 and 50 to 75-year-old age groups experienced an overall increase in monthly colorectal cancer screenings, indicating that there has been effective public health messaging and uptake in all age groups. Minority and vulnerable patients were screened at lower rates in the 45 to 49-year-old group after the USPSTF guideline changes, potentially indicating that there may have been some disparities in uptake and room in the future for public health messaging. Overall, these findings demonstrate the effective implementation of guideline changes, translating to the uptake of colorectal cancer screening in younger individuals. This may inform future studies on incidence and clinical effectiveness on screening in the future. Thank you very much for your time and attention. Please let me know if you have any questions or comments.
Thank you very much, Alyssa. Oh, there you are.
Hello.
Thank you so much. That was the second or third time I'd watched your video, and I enjoyed it. So that said, first I'm going to ask Norm, are there any questions from the audience at this time?
Not yet, but they're coming, I'm sure.
Okay. Well, there was one statistic that was surprising to me, and well, actually, I'm going to say that for a minute. Let's go to the question from the audience, from Sarah Crawford from ACHI. What types of screenings were included? Did you see any differences in the type of screening 45 to 49-year-old patients were getting versus those who were older?
Yeah, that's a great question. So this is looking at facility claims. So I leveraged the codes for the screening encounter itself, as well as the different screening modalities. We don't get, unfortunately, things that I would love to see, like Cologuard, those at-home screening tests, which are gaining in popularity. But we do have some insight into things like colonoscopy versus flexible sigmoidoscopy versus some of the fecal immunochemical tests. At the lower ages, they tend to be more colonoscopy, which is also what you kind of hope to see, because a screening colonoscopy is just not a screening test. It's also you cut out any polyps that are there. So it is also some intervention and prevention while you're in there, as well as screening. So in that younger group, it was more colonoscopy, but with the caveat that in facility billing, we do have kind of a blind spot to anything that is happening, through the mail or, at home.
Thank you very much. ACHI's done some work in colorectal screening, and that is the genesis of that question.
Okay.
So in the stats, you talked about there was a pickup in Hispanic.
Yes.
That was interesting to me. What do you think caused that?
I'm not sure if it's messaging. So some of the demographic differences, I think, may be attributed to things more like pre-existing recommendations that were, broadly in place. So when we're seeing that higher representation of Black patients in that earlier period, there have been some professional societies who had different race-based suggestions to initiate screening earlier than the general USPSTF. So I'm not sure if something like that is at play. I don't know of anything specific for Hispanic patients like there are for Black patients, but I'm wondering if that is something at play or if it's more just access. I think that's definitely something worth diving into further to kind of to see if it's something more representative of something that is an access versus something else.
Thanks. Great. It's interesting. All right. New question. What are the key factors affecting the lower rate of screening in the majority group after the update? Is it a messaging issue, or are there other factors?
I think that's something that I would like to try to get at in the future. To my point before, there were some messaging, there were some societies that had recommendations for race-based screening to initiate earlier in Black patients. So that might have contributed to them potentially being overrepresented in that earlier sample, and then it might be more of a more representative sample later. But I think that digging deeper into something like the patient access in the characteristics and their vulnerability, so not just their race, but some of the other social drivers, to see if it was a disparate rollout versus just prior to those recommendations, if it was just being leveraged higher in minority communities.
Okay. New question. Were statistical significance tests used, and were any variables controlled for?
That's my next step for fully adjusted models. There were statistical significances in the volumes and all of the demographics. A lot of that has to do with the volume of the sample itself. So there were over 6 million screenings here. And when you get that many screenings, everything little, even if it's minor, tends to be statistically significant. So it's really just that bivariate. So I want to, in the future, go into more fully adjusted models to control for a lot of that.
Great, thanks. Well, Norm has asked to bring all of our guest speakers on stage. There we go. Thank you so much. Well, I'll begin with a question for all of you. For each of you, what are your next steps, and will there be follow-up work? Well, let's wait. My apologies. There's another question from the group. One more question for Alyssa. Do you exclude hemorrhage as an SF? No, it's not for Alyssa.
Yeah, I can take that.
Thank you.
So hemorrhage typically is not an SMM indicator, so we do not include it in our analysis. We focus mainly on the 20 indicators and exclude transfusion also. So hemorrhage is not part of the indicators we look at.
Thank you, Godwin. Okay. So my question is, I said, what are the next steps, and what will there be follow-up work? Deja, we'll start with you. Yours, what would be next in disseminating the information about the foundation?
Yeah, so our next steps are, as always, just to continue to be a support to our network. We are hoping to actually we also offer like cohort-based technical assistance that we hope to be rolling out within the next year or two, where we can support some jurisdictions. So we're excited about just continuing to support the efforts. We do have a forthcoming equity and practice equity toolkit that we will be disseminating at the beginning of the year that we're super excited about. But those are some of our next steps in terms of how we support our localities and jurisdictions.
All right, Nairi and Godwin, what are your next steps with your work?
So we've kind of gotten the ball rolling on that a little bit with the Learning Collaborative. It's just kind of like making sure that hospitals are like engaging with each other and comparing and contrasting like what indicators they are also having challenges with correctly flagging, and also I guess other issues they're having with their QI processes. And I guess another next step, and this is kind of like something a little down the road, but potentially flagging false negatives from hospitals could be like helpful in the future. But that requires like engaging potentially hospitals that have their own internal systems, and being able to like hospitals that are able to have their own cases that we can like compare with our own algorithm that they identify internally. But that's still like a work in progress. We're figuring that out. Godwin, do you have any other thoughts?
Really, the next step is sort of to grow this project. As I said, it's a 5-year project we're trying to run. Our goal is to get every hospital, all the better hospitals enrolled, and hopefully support them to develop their own internal system for identifying SMM. We ultimately want them to be able to sort of see their own cases in real time and review them as they happen.
Alyssa, and then we'll get to the question.
Yeah, I'd like to dive more into a lot of the modalities to the point before, just to look at the differences in uptake and the before and after by the modalities. Also doing more fully adjusted models. And then the next step, going to, I think kind of hinting at this question, is the Vizient Vulnerability Index looks at a high level at life expectancy at the zip code. But at the zip code level, it adjusts based on 9 drivers of health domains. So public safety, transportation, health access, and those all are looking at the life expectancy based on those. So I want to look to see if some of those uptake measures are more driven by some of those domains of health over others.
Okay, that's interesting. All right, so here's a question. Did you discover any interesting findings when looking at life expectancy based on zip code?
So I think that might be going to the Vizient Vulnerability Index at a high level. So I did notice differences in the uptake in that post period. So individuals who were getting screened tended to be from less vulnerable areas. So that might hint at access issues or messaging issues, health literacy. That I'm not as clear on, but overall at the higher level, those patients were more commercially paid and less vulnerable.
Okay. All right, I have one more question. We'll start with Godwin and Nairi. Is there a focus or a component or something that you wanted to include or want to include that you weren't able to?
Yeah, that's a good question. Right now, the way our process is structured is we analyze the data, generate an Excel spreadsheet, share with hospitals, receive that in Excel, and then go to Tableau, which is like multiple steps to achieve a goal. What we really would like to do is to sort of automate this in one place So have like sort of a Tableau system where we can put the cases there, how clinicians can review the cases in one place, and then we can make the changes and update our dashboard in the same place. So that's something we're hoping to move to. But of course, that requires a little bit of tinkering with our current process, some funding as well, and then really, building this really amazing structure that will be helpful to hospitals. But we're still thinking about how to get to that stage.
Alyssa, what did you want to include but couldn't?
I kind of hinted at this before, but I would love to know the impact of individuals who are getting tested through Cologuard. I know anecdotally, someone who works for the state of Illinois who just got mailed a kit at home for screening. We're not going to capture that in a facility database because there's no facility charge for that. They're just mailing it home. But it is getting billed through an insurer somehow. So if individuals have access to, higher, APCDs or something where they could see all the claims, that would be interesting to look into, because right now that uptake, that impact isn't as clear. We do know that there are huge gaps in screening. There's, about a third of the country are not up to date on their screening recommendations. So there's a lot of room to go. So it would be interesting to quantify, how has that gap closed with tests like Cologuard, and then recently approved the Shield blood test. So there's new technologies that can help close that gap.
Interesting. Deja, close us out. So what would you like to add to your process of building a foundation?
Yeah, I think we want to one thing that has percolated up from our jurisdictions has been a lot of questions about the role of consent. And so we want to help folks kind of explore some frameworks about of how to navigate consent and when it's best to rely on exceptions in the law. So that's one thing we're thinking about. And also too, another thing we're thinking about is just the implications of AI, as I imagine most folks are wrestling with, that we just haven't haven't thought as deeply about the implications of that. But those are two areas that we see ourselves wanting to figure out ways to better support our network with, is the role of consent and just the implications of AI.
I appreciate your commenting about consent, because depending on the study question, the data available, nothing happens without it. So, well, thank you, everybody. What a great session. And I want to wish everyone a great afternoon. And Norm, I'm going to turn it back over to you.
Yeah, truly. Thank you, everyone. These are fascinating. And also thank you to our attendees for all of the questions and comments. It was very engaging. Coming up next, we have our networking deep dives. There are 4 networking lounges that you can meet our experts. And again, they are capacity controlled. So if one is full, go to another one, and hopefully you can find space there. And then we will see you at the next sessions after that, or in about a half an hour. I believe they start at 12:50, if I'm not mistaken. So we'll see you all again soon. And thank you all for your time.
Thank you, everybody. Great. It was great fun.